Hi, everybody. It is 6 p.m. in Paris, 5 p.m. in London, noon in New York, and it is my great pleasure and honor to welcome you all to this ICH webinar. A very warm welcome to all of you, and thank you for joining the educational activities for the International Academy for Clinical Hematology around the globe and across the hematology field. And today, we do have a very, very nice and topic, namely sickle cell disease. The webinar will be delivered by a very distinguished speaker and expert in this field, namely Professor Mariane de Montalembert. She is a professor of pediatrics. She is a top expert in hemoglobinopathies. She works at the Necker Children's Hospital in Paris, in France, but she's also member of the European Hematology Association board. So, Mariane, thank you for accepting our invitation. We're very pleased and honored having you with us today. And obviously, guys, please, this is a live webinar, so please don't hesitate to share your questions. And at the end of the webinar, we'll have a Q&A and a discussion with Professor de Montalembert. So Mariane, the floor is yours. You can share your slides and we will reconvene in whenever you're ready. Fantastic.
That's okay for you? You can have the slides?
Yes, we can see them very nicely.
Okay. So first, thank you to all the members of International Academy for Clinical Hematology. And thanks a lot, Professor Moti, for this very kind invitation. A lot of genetic studies let us think that the sickle cell mutation originated around 7,000 years ago in Central Africa. There are some important dates, 1910, with the description of the first case of sickle cell anemia, 1949, with the evidence of the abnormal HbS hemoglobin, 1956, where it was shown that the disorder is caused by a single amino acid change, and 1978, pinpointing the DNA mutation. When you have a major sickle cell disease syndrome, you may have a double copy of hemoglobin S. But, and this is the most frequent genetic case, but alternatively, you may associate HbS with HbC, which is especially frequent in Western Africa, or with the beta thalassemia, beta 0 or beta plus, and this condition is more frequent in North Africa and in the Middle East. As you know, HbS mutation protects against Plasmodium falciparum infection. We do not know exactly how many people are living with sickle cell disease in the world. It is estimated, but there are no real systematic program of neonatal screening in most African countries. We estimate that there are 300,000 sickle cell disease babies born every year. It is estimated that in the States, there are 100,000 sickle cell disease patients. We know, thanks to neonatal screening, that in France, one baby is affected with the disease out of 1,300 births, giving approximately a population of 30,000 patients. You know that the beta gene is on chromosome 11, with a mutation giving rise to beta S gene, and giving rise to the production of beta S globin chain. This chain has an hydrophobic motif, and hence, in the oxy conditions, there is a polymer of beta-S globin chain which are tied together to protect the hydrophobic motifs, and the polymer of the oxyhemoglobin S gives rise to vasoocclusion, sickling, and hemolytic anemia. The process of sickling takes 3 to 10 seconds to occur, but you know that the red cell leaves the capillary after 1 second. Therefore, to explain that there is vasoocclusion in the capillary, you have to think that either the time needed for polymerization, which is called the delay time, is shorter, and the factors controlling this time are red cell hydration status and percentage of fetal hemoglobin. Or the red cell stays longer in the capillary. This time is called the transit time. And indeed, we know now that the red cell stays longer in the capillary because it is sticked to the surface of vascular endothelium through a lot of bridges. And here, I just would like to underline this bridge because it is provoked by stress. And we see that stress is an important factor in the generation of vaso-occlusive crisis. What we know now is that sickle cell disease is not only related to red cell, what was believed for many years, but in this vaso-occlusion, there are not only red cells, but there are also neutrophils. And here you see this beautiful cartoon made by Slimane El-Ali and published in Hematologica. Here is the neutrophil. Is tightly linked to the activated endothelium via the link p-selectin on the surface of activated endothelium and its ligand on the surface of neutrophil. And this link is also responsible for the link between neutrophils and platelets, and in turn through MAC1 with the relation with red cells. But neutrophils are also responsible for the production of reactive oxygen species and generation of NETs. Monocytes are activated by a lot of hypoxemia, platelet growth factor, a relation with platelet monocytes aggregate, so TLR4, and through the NF-kappa B pathway is responsible for production of adhesion molecules. Macrophages and monocytes are responsible for the production of inflammatory mediators. And in our unit, we have a special attention to mastocytes because most probably through the production and the release of substance P and histamine, they are responsible for neurogenic inflammation. But as well, hemolysis gives rise to free hemoglobin and to arginase, which in consequence decrease the production and the activity of nitric oxide, and this has been related to several clinical manifestations such as priapism, leg ulceration, pulmonary hypertension. And finally, we have to leave the simple model of only the single role of red cell with polymerization of the oxyhemoglobinous to consider that there is a network of cells responsible for the disease with coagulation disorders, platelet activation, inflammation, endothelial dysfunction. And all this complex is regulated by several factors such as fetal hemoglobin. Indeed, the tetramers, the hybrid alpha-2 beta-S gamma and alpha-2 gamma-2 HbF do not enter into the polymer of the oxyhemoglobin S and block the elongation of this polymer. And we knew for many years that in fact there were major protective effects of HbF because newborns are asymptomatic, and this is an old story because it was published 30 years ago, but patients with higher level of HbF have the higher probability of survival. And now we understand perfectly why one of our targets is to increase fetal hemoglobin. which is done either using hydroxyurea or gene therapy. It is easy to make a diagnosis of a major sickle cell disease syndrome when you look at the fraction of hemoglobin. When you are SS or SBT0, you have no A and you have only S. When you are SC, you have the same content, proportion of S and C. When you are S beta plus, you have some production of A, but of course, quite lower than the quantity of S, which contrasts with the condition when you are AS. You have as well A and S, but quite more A than S. There are several techniques: electrophoresis, isoelectric focusing, and HPLC. But these techniques are rather expensive and cannot be performed in Africa most of the time, where different techniques have been developed, such as immunoassay. This one is called a Sickle scan. No electricity is needed. It takes less than 10 minutes. It needs only a drop of blood, and it is relatively inexpensive. And it has been shown that minimally trained medical staff could give a high sensitivity and specificity to perform a diagnosis of sickle cell disease, and these techniques are more and more used in Africa. Now we are moving to the management, to the clinics, to the management of the disease. This management must be implemented early, at best after neonatal screening. No one is living close to a reference center, and it has to be collaborative with interaction of proximity centers and reference centers. It is a lifelong disease. We have to create a partnership with parents to inform them of genetic transmission of the disease and management, to teach to the parents to be reactive to signs prompting for emergency department visits, and to make projects for the future of the child. Of course, to adapt care programs at the facilities existing in the patient's country. Here is a game we have created to explain to the parents genetic transmission, but very often parents do not believe us, and they think that the disease is related to sorcery. Complications of sickle cell disease may be reversible when they are related to polymerization of the oxyhemoglobin S. The first cause for death so far is bacteremia. Second cause for death is acute splenic sequestration. Third cause for death in children is stroke. But there are of course also pain and acute chest syndrome with a highly variable frequency. As the child is going older, he has endothelial dysfunction, and this dysfunction is not reversible. This complication, infection, pain, worsening of chronic anemia, severe vaso-occlusion such as acute chest syndrome and stroke, they create a vicious circle. But thanks to neonatal screening, appropriate use of transfusion, hydroxyurea, nowadays median survival of children with sickle cell disease in high-income countries is about 98%. Here in France, in the United States, in Great Britain. This is true in high-income country. It is not true at all in low-income country. Here is the example of Tanzania. Given that in Tanzania, they have a special interest in sickle cell disease and a dedicated program. But here is the mortality rate in Tanzania to be compared with the mortality rate in the US. The severity of the disease varies widely according to patients. There are few asymptomatic patients. Most patients have intermediate forms. In my country, the median of hospitalization is 1 vaso-occlusive crisis per year for a child. And some patients are extremely severe with pain, strokes, acute chest syndromes, and as patients are getting older, the percentage of severe patients are getting is increased. Why? Because we have seen that there are so many polymorphism in each cell, in white cell endothelium, in red cell coagulation. It is a sort of it's a combination, a unique combination, but also this is my hospital, Necker, and this is a street in Africa. And also there are socioeconomics and psychological factors. And we are not able to predict the severity of the disease in a newborn. But what is of outstanding importance is that in sickle cell disease, you have to organize care so that appropriate care must be given in emergency. Because I estimate that there is in some cases, such as splenic sequestration, fulminant infection, we have, let us say, less than 3 hours to bring antibiotic, transfusion, or morphine. So now we are going to see what is implemented at birth. We try to prevent invasive pneumococcal diseases, which in 2024 are everywhere the first cause for death. 4 doses of conjugated vaccine, followed by a polysaccharide vaccine, since you know that conjugate vaccine must precede polysaccharide vaccine, which can induce hyporesponsiveness, combined with daily prophylactic penicillin. Pain is a hallmark of sickle cell disease. There are triggers: cold, dehydration, infection, hypoxemia, clinical signs. This is a dactylitis. What I would like to underline is that when you are painful, you fear to be more painful and you increase pain, meaning that psychological support is extremely important in sickle cell disease. There are no specificities in the management of acute pain in patients with sickle cell disease. As usual, you have to assess pain intensity, look for a cause, very often infection, choose analgesic, very often morphine, admit patient if needed, be empathic, which is really important, and re-examine to the patient to avoid, for instance, opioid overdose. What is characteristic? When you are a child, you have a nociceptive pain triggered by stress, weather, infection. The child is painful, but then it goes back to normal. But as you are getting older, you have sometimes extended hyperalgesia after vaso-occlusive crisis or opioid-induced hyperalgesia. And you have not only nociceptive pain, but also neuropathic pain with new triggers such as depression, anxiety, sleep disorders. And finally, you go from median pain to high pain to median pain, and you are never painless. And this is demonstrated in this study which gathered 1,500 patients. Look at that. The number of painful days were 3 ± 2 per week. And the physicians are not always aware of this pain because 25% of those crises were managed at home. A special feature is acute chest syndrome. The patient comes for fever and cough, and then he gets this pulmonary infiltrate, meaning acute chest syndrome. Here, in this case, he worsens, go to emergency unit. He has an exchange transfusion, and some hours after is improved. This is the first cause for death in adults, acute chest syndrome, related to bacteria or to viral infections, to coagulation disorders, to sickling in pulmonary vessel, to fat embolism. It is extremely severe, needs most of the time to be treated in intensive care unit with adequate pain relief, non-invasive ventilation, antibiotics, and very often transfusion or exchange transfusion must be considered. The median hemoglobin level in sickle cell disease is around 8 ± 1, and retics are usually at 200,000. I told you the second cause for death in children was acute splenic sequestration. The red cell, as you know, they have to go through these very tiny interendocellular slits, but when you are sickled, you can't. And the red cells are kept within the spleen with a hemoglobin drop above 2 grams per deciliter and then spleen size increase. Appropriate education of parents about signs prompting to go to emergency department can suppress the mortality of this complication. Third cause for death, stroke. There are, as you can see, overt stroke. You see, maximum of occurrence between 2 and 5 years of age. Moya, it's not easy to see, but there is a stenosis of internal carotid artery, and you have the creation of a network of fragile vessels which can disrupt, and there is a hemorrhage. Or this tiny little white point, you can see that only using MRI. It is a silent cerebral infarct. It is very frequent. It is not so silent because it is related with cognitive impairments. In fact, we know that there are a lot of factors to contribute for stroke: sickling, inflammation, thrombus, extreme adhesion. And we do not know which factors are the first or the main ones, but what we know is to prevent a stroke. And here is a very simple tool called transcranial Doppler. And just you check the velocities in a carotid artery and middle cerebral artery, and you look at the velocities. And when they are increased, it means that there is a high risk of experiencing a stroke. After an abnormal TCD, you offer a period of transfusion. And if there is no worsening of the lesions and a normal MRI, you can switch to hydroxyurea. While after a stroke, the best treatment is to offer all lifelong transfusion, or if you have a donor, a bone marrow donor, of course, to perform a bone marrow transplant. But in Africa, almost no country can perform monthly blood transfusion, and therefore hydroxyurea may be an option for stroke prevention. I am a pediatrician. I see this part of the iceberg, vaso-occlusive crisis infection, but I know that under the level of the sea, there is a development of chronic organ damages. The more than patients are very anemic, and when patients are extremely anemic, they may develop those complications. In adults, a lot of complications, strokes as well, sickle, hepatopathy and nephropathy, avascular necrosis of the hip, bone infarcts, sickle retinopathy, pulmonary hypertension, leg ulceration. Look at those data. These are the median age at death in United States, 44, in France, 41, in Brazil, 32. And if we compare the life expectancy of patients with sickle cell disease with patients of the same social category or general population, it's quite decreased, and the quality of life is totally decreased. This French cohort was studied very carefully, and they showed that the median age at death in Henri Mondor in France was 37 years, and the majority of patients died from acute complication occurring on a background of chronic disease. Acute kidney failure on a background of chronic kidney failure, hepatic, cardiac, pulmonary hypertension. And now we are going to move to treatment. Transfusion is a major treatment in sickle cell disease. 80% of patients have been transfused before the age of 18 years. The aims of transfusion are either to increase oxygen carrying capacity, which can be made using acute simple transfusion, or to replace rigid red cells by deformable ones, which can be made either by simple transfusion or exchange transfusion. We have said that median baseline was 8. We may be obliged to transfuse a patient with acute splenic sequestration, parvovirus B19 infection, acute infection in Africa. The most frequent cause is malaria, painful crisis, or we will detail this severe complication, which is called delayed hemolytic transfusion reaction. You may perform a top-up transfusion. You have an acute anemia, or monthly transfusion. In children, mostly to prevent a stroke, and in adults, mostly because of chronic organ damage. You may use simple transfusion, easy, manual exchange transfusion, or erythrocytophoresis, which is the best but most expensive technique. I would like to underline these aspects. There are differences in blood group distribution on red cells between blood donors, here in blue, in this scheme, which was kindly provided by France Pirenne from Henri Mondor. And in pink, these are the patients. You can see that the distribution of Rh phenotype is extremely different. And there, hence, patients with sickle cell disease have a higher risk of developing antibodies against red cells. And we have problems because there is a limitation of blood donation from communities with a high frequency of sickle cell disease. And we can have these very dark urines and observed 1 to 3 weeks after a transfusion, a delayed hemolytic transfusion reaction. Another important, of course, treatment is hydroxyurea, which increases fetal hemoglobin proportion, decreases number and activation of neutrophils, and is a nitric oxide donor. This trial was a pivotal study. It is not recent, 30 years ago. And I just would like to underline that when comparing hydroxyurea to placebo in patients with severe disease, you do not cure the patient. The number of acute vaso-occlusive crises decreased from 4.5 to 2.5. And sometimes the patients are deceived. They believed, disappointed, because they believed they would be cured, but not, they aren't, but they have less painful crises, but they would like to have no painful crisis. This very good effect was also shown in young children, decrease of pain events, acute chest syndrome, need for transfusion. And it was also observed, but this is a not randomized study. Patients are their own control. Decrease of painful events, of vaso-occlusive pain, transfusion, and death. Hydroxyurea is effective in most patients when taken regularly. Because sometimes people say, well, I had a crisis, so I do not take the drug, which is not active. No, you have to inform them that it won't be a cure. There is virtually no side effects when have been identified to date, with the exception of an impact on fertility, the reversibility of which is possible, but yet to be determined. You have seen that that many patients do not take hydroxyurea, perhaps because they are disappointed. And there are many other drugs targeting not only red cells, but also coagulation, and we're going to see them. First, approaches to inhibit HbS polymerization. You be desiring to induce fetal hemoglobin synthesis, increase oxygen affinity, or reduce 2,3-DPG concentration. You have seen that the best and more important drug to increase fetal hemoglobin production is hydroxyurea. This drug is interesting because, in fact, it is a combination of tetrahydrouridine and decitabine, and perhaps it could be active when given only once a week. But we are waiting for more data. What about stabilizing hemoglobin in a high oxygen affinity state? It was done by voxelotor. It was a publication in the New England. People that received placebo, 900 or 1,500 milligram. And clearly, patients with 1,500 milligram had an increase in hemoglobin and a decrease in hemolysis data, and a trend for reduced vaso-occlusive crisis. This led FDA to approve the treatment for everyone, adults and children over 4 years of age, while Europe decided to restrict to treatment of hemolytic anemia in patients older than 12. Another family, the activators of pyruvate kinase activity. In sickle cell disease, the red cell have an increase in 2,3-DPG concentration, a decrease in oxygen affinity, and a decrease in the production of ATP in red cells. There are two drugs. This one is mitapivat, and here you can see the impact. It decreases 2,3-DPG, increases the vitality of red cells by increasing ATP production. There are very good clinical results in this phase 2. Rise up, you have an increase in hemoglobin level and a tendency to a less painful crisis. Phase 2, phase 3, ongoing. And the other drug is etavopivat. Phase 1, excellent results. Here are the data. This is a phase 1, reduction of hemolysis, increase in hemoglobin, and phase 2, 3, ongoing. L-glutamine is an antioxidant. It was approved by FDA because it was shown that there was a decrease from four crises in the study period to 3 crises, but it was judged as sufficient by US, but not in Europe, and it is not licensed. It would be interesting to be able to target free hemoglobin and free heme using those drugs we are in current investigation. And there is a complement dysregulation in sickle cell disease and a lot of anti-complement molecules. But then we have seen that sickle cell disease was not only related to red cell, but also to white cells. And there are drugs targeting the specific P-selectin and its ligand relationship. And the most important drug is called crizanlizumab. Crizanlizumab is an anti-P-selectin. And in this phase 2 study called SUSTAIN, it was a very striking decrease of vaso-occlusive frequency by 45%. And hence, United States licensed the drug as Adagveo to reduce frequency of vaso-occlusive crisis in pediatric patients aged 16 years and older. The indication was pain. And the results are not yet published. I could not show you the results. But 1 year ago now, we had a message from EMA and recommending revoking the marketing authorization for this drug in Europe. Because there was no clear decrease in the phase 3, the name was STAND, between the treated arm and the placebo arm. The point is that there were methodological weaknesses and a lot of methodological weaknesses. The fact is we cannot use it now in Europe. Another anti-P-selectin undergoing study is inclacumab. I wanted to say a word about omega-3 fatty acid, which perhaps are interesting, but a lot of trials and not many publications, honestly. And we are going to finish with hematopoietic stem cell transplant and gene therapy. I have taken this meta-analysis. A problem with the meta-analysis is that you gather everything. And this one is the most complete meta-analysis I have seen. But for instance, here in children, it is more clear because we know that there were many myeloablative conditioning and match-related donors. So globally, you can see that there is a non-relapse related mortality of 4%, acute GVH 20%, and chronic GVH 10%. These, let us say, excellent results led some experts to propose hematopoietic stem cell transplant to all children with HLA identical sibling, while the impact on fertility and this mortality rate of 4 to 5% makes that some other experts restrict the use of hematopoietic stem cell transplant to symptomatic forms. There is a discussion on haploidentical transplant, and currently it is mostly considered in research protocols. Unrelated donors are not good donors in sickle cell disease, in opposition which was observed in thalassemia. Gene therapy, gene editing. You may add an anti-sickling gene, which was the first option taken by Bluebird, or you may edit. You may edit either factors controlling fetal hemoglobin production or the mutation by itself. Here is what was done by Bluebird in orange. You have the addition of hemoglobin. It was A87Q. And you can see that there is 40% of anti-sickling hemoglobin with a pan-cellular distribution. Other option, which is the Vertex approach, is to disrupt the activity of a BCL11A gene, and meaning an increase in the production of fetal hemoglobin. And these results were published 15 days ago. And these, you can see that there are 44 patients, short follow-up, but that almost the vast majority of patients have no more crises, but some patients still have some painful crises. I have taken this example just to show you that if you have a patient with no donor, if you have a donor, it is very simple. But when you have no match-related donor, you can perform when the patient is painful. Monthly transfusion, it works, but it induces iron overload and venous access problems for sometimes alloimmunization. Combined treatment, not so much. We do not have any more crizolizumab, haplo-identical transplant, or gene therapy, which is really poorly available today. I would like to emphasize the role of parents and patients empowerment. And I am working in a unit where it is a very target. We organize games, therapeutic education sessions, summer camps. And I have finished, and I would like to thank you for your attention, and I will be happy to answer to your questions.
Thank you, Mariane, really, for a very, very beautiful talk. Very comprehensive overview. You managed in less than 40 minutes to walk us through since pathophysiology to gene therapy. This is really fantastic, and I'm very grateful. So we have already a lot of questions, actually. For instance, we have Dr. Cyan Roy asking, like thalassemia, is there any pre-transfusion target to guide the transfusion frequency in sickle cell disease?
Excellent question. For sickle cell disease, we try mostly to control HbS percentage. And finally, to prevent a recurrence of stroke, the threshold is 30%. And you can get this 30%, you try not to increase too much the hemoglobin level versus the baseline level of the patient. In thalassemia, they are always very low. But in sickle cell disease, they may have a stroke while having from 7 to 10 grams per deciliter of baseline hemoglobin. And hence, you try not to be higher than 11, but mostly to control HbS percentage.
So we have actually here, I mean, you're recommending this monitoring with HbS percentage, but we have another question about whether this is really cost effective in low and middle income countries, and whether one should, if you have another option maybe to do this.
Well, we know that in most all African countries, it is not simply possible to make a monthly transfusion program. Because there is no blood donation, in fact, and so they have no blood reserve. So I think that when you have a stroke or when you want to prevent a stroke in Africa, you need absolutely to receive hydroxyurea. And we are working on the best way to make hydroxyurea available for all African patients.
Excellent. Thank you very much. We have another question from Dr. Abey Bave about, I guess, in case of surgery, is this an ideal level of HBS to achieve before going into surgery?
Excellent question. First, I would like to make some publicity. The more that it is totally free. We have written guidelines. Ah, yes, but it is in French. So for people reading French, we have the guidelines and all these answers, all these questions are addressed. And thanks to EHA and Eurobloodnet, this document will soon be translated. So you will get it for free and in English. So it depends of the length of anesthesia. If the surgery is, let us say, roughly shorter than 1 hour, you can go on without a lot of preparation. But if the anesthesia time is longer than 1 hour, you need to decrease HBS, and it depends. If the surgery is really severe or very difficult, or the patient is very severe, you have to go less than 30%.
Okay. Another question about transfusion exchange. What is the current indication?
The most frequent in exchange transfusion, for instance, in my unit, 10% of children are undergoing transfusion exchange. Some of them because they have some risk factors for having a stroke, such as abnormal TCD, or because they have had a stroke. And the other is because they are non-responding to hydroxyurea, and albeit they receive hydroxyurea at the maximum tolerated dosage, they go on experiencing pain or acute chest syndrome. These are, for children, the main indication: failure of hydroxyurea or stroke prevention. And in adults, it's mainly for chronic organ damage.
Excellent. Thank you very much. So we'll move now to, we have a lot of questions about treatments, guys. I'm not sure we're going to have time to take all of them, but we have Dr. Daniela Werneck from Brazil, and saying that in Brazil, they can start hydroxyurea from 9 months of age, even without pain. Do you think, or do we have data that this is going to change the natural history of the disease, given this very early start?
Well, what is first, thank you. And thank you and hello to Brazil. I've been several times to Brazil and it was always a pleasure. In Brazil, there are 4,000 babies born every year with sickle cell disease. 4,000, it's really a huge problem. And so I've lost the question.
So because they start very early, since
Yes,
eight,
yes,
nine
yes,
months,
you're
is
right.
this going to be useful over the
Yeah,
long term?
well, it's the recommendation is to start at 9 months in the United States, in France, in Great Britain, in Germany, in Italy. So there is a sort of consensus to start. And in fact, the license is for 2 years of age, but they're asking for an extension of indication to start at 9. I hope, yes, Mohammed. I hope. I have no proof, but I think it is. It can be hoped that it will improve. But as these programs have been started recently, I can't prove that it will work. But we really hope that it will.
Okay, thank you. We have, I think, a very broad question similar to this. This is Dr. Esra Gulduran from Turkey. Do you believe that all of these novel therapy approaches that you have described are going to be over the long term better than hydroxyurea?
No, I think that hydroxyurea is a sort of miracle, honestly. I think that. No, it works on everything, hydroxyurea, because it decreases neutrophil activation. It is a nitric oxide donor. It works on everything. So I think that really it is the king molecule. But the problem is that many parents, they they do not give the drug because they fear the impact on fertility. So there is a room for these drugs, or in combination, you can think that hydroxyurea plus etavopivat or hydroxyurea plus voxelotor will be the good drug. But I know, Mohammed, you are going to tell me, but why don't you transplant them? Is it your question?
No, I didn't ask it yet. It will come. It will come. But let me finish with hydroxyurea because you're excited about it. We have a question about the long-term side effects, saying that in the context of myeloproliferative neoplasm, it was shown that over the long term, after more than 20 years, and I remember this was a communication at ASH a few years ago, there is a risk of leukemic transformation. Do we have a similar pattern in sickle cell, or we have enough follow-up to claim that this is safe and should be pursued?
We will never have enough follow-up in a complication which happens rarely. What I say is that for many years, at the time where hydroxyurea was not existing, we knew that there was an increased risk of myeloid event in sickle cell disease. And it is not related to hydroxyurea because 30 years ago, there was no hydroxyurea. So we know that patients with sickle cell disease have more myeloid leukemia. It has been described. The reason why is really interesting. And we know that without hydroxyurea, patients with sickle cell disease experience more cancer than the others. It has been published, I think it was in American Journal of Hematology by Jean-Antoine Ribet, that perhaps reducing hyperhemolysis, sickle cell disease could reduce this risk of transformation.
Okay.
And I have done a survey which was published in American Journal of Hematology, and we made a review of all cancer cases. And really, I do not believe at all that hydroxyurea increases this risk, but really.
So clearly your message, and this is an important message to all of us and to everybody, please don't forget hydroxyurea in sickle cell. It's easy, it's cheap, it works very well, and the side effects are not a matter of concern. Another question about hyperbaric oxygen therapy to reduce crisis. Is this something frequent, useful, proven?
May I say no to all your items?
You
We,
can, of course. This is what I'm
I
asking.
think there is no there is no meaningful publication on this topic, and it is not used. But almost every 5 years, someone says, I am going to try. But it does not publish the results. So I don't know, but I would not be really tempted to try it.
Okay. Another question about the optimum. Is there a sequence or a hierarchy between hydroxyurea, voxelotor, and crizanlizumab?
I should say that hydroxyurea works on everything.
Okay.
Voxelotor works. I do think it works. I do think that the STAN trial was hampered by technical problems and design problems and by COVID, because at this period of time, it changed the way people were going to hospital. So I think that they had too many methodological problems. I am convinced that it works, crizanlizumab, but it works on pain. And voxelotor works on anemia. We do not know whether it is active on pain. So hydroxyurea, everything. Anemia is voxelotor, and pain is crizanlizumab. Crizanlizumab does not increase hemoglobin level at all.
So we have a few questions about the novel gene therapies, and there are a lot of questions about the cost, Dr. Saud Abu Harbish. But we have also a specific question from Dr. Fahad Al-Sheri from Saudi Arabia about the CRISPR-Cas9 technique in this specific situation. Any thoughts on this?
Well, the cost of a sickle cell disease is awful. So, the cost of gene therapy so far it is 1,900,000 euros. So it is awfully expensive. The cost of when someone from, let us say, Saudi Arabia comes to Paris for a for a bone marrow transplant, he is asked to give 300,000 euros, and he has to stay in Paris for 1 year. So it is expensive. I think that there are a lot of problems. There is not only the problem of the cost, which is meaningful, but there is a problem of the availability of bone marrow transplant units. For instance, in my center, Vertex opens. I am very happy with the fact that Vertex opens, but I have a bottleneck. I have a problem. I have only few beds, few nurses, few beds, and I have no the ability to provide more gene therapy to more patients because I have no room, no nurses, and no one, finally. It is not the cost, it is the problems of availability of we have to think there are really many sickle cell disease patients. And we have to think, do we change all our bone marrow transplant unit? Because there will always be leukemias and emergencies, and we have to think about this global health problem.
No, absolutely. I agree with you, and I keep on repeating it. We here at the IACH, we clearly and strongly advocate for accessibility, availability, and affordability of all therapeutic innovations to all patients everywhere. Patients are important everywhere, and this is our moral responsibility to fight and work in this direction. Since we're talking about transplant, Marianne, we have a question about, I don't think you mentioned cord blood transplant. Is this something trendy or useful?
It is made. The cord blood is not better than bone marrow. We have no superiority. It was hoped that it would be better, but it is not better. In terms of quality of transplant, it is not really better. So, for instance, in my country, every time a mother has a sick child, we preserve the cord blood of the other children in order to be able eventually to perform a cord blood transplantation. It does not change really the point. The problem is that there are very few, as you know, there is a shortage of matched blood donors, not blood, of matched bone marrow donors, because less than 20%, it is estimated that 18% of patients have a HLA matched bone marrow donor, which is a short number, a short proportion, and it is really a problem with that. But we in France, we have the tradition to keep cord blood, but it does not change, in fact, so much the question.
Okay, wonderful. Okay, I'll take one last question, which is about the management of these patients during pregnancy. Are there any specific recommendations?
Yes, there are a lot of recommendations and a lot of contradictions. These are high-risk pregnancies, and we know that there is an increased mortality of mothers and of children. Really, the mothers, they have to be followed up in a very specific, in the highest protection units with a high competency on pregnancy, on blood transfusion, and on sickle cell disease. And there were periods where all pregnant mothers were transfused and periods where none of them were transfused. Now it depends on the condition, but very often pregnant women are transfused during the pregnancy, very often.
Wonderful. So we have, I'll share just one last comment from Dr. Claudia Bettoni, who absolutely agree with you that every single sickle cell patient, as soon as possible, should receive hydroxyurea. and she's reminding us that the first reported case of bone marrow transplant for sickle cell was published in 1984 in a child
Yeah.
who had developed acute myeloid leukemia. Thank you, Dr. Bettoni,
Yes, absolutely.
for this nice comment, and you have very nice comments, and big thanks from Dr. Ahibab, Dr. Isra Gulder, and many others, actually. So, Marianne, it has been a
Thank you.
true pleasure, a true delight having you with us. I think this was really a superb webinar, and we at the IACH are extremely grateful to the time you dedicated to prepare very didactic talk, actually. And I believe sickle cell is a true public health problem, but also it's a model of innovation, not only in terms of gene therapy and bone marrow transplant, but also even sometimes how optimizing the use of an old small molecule can make a big difference in the life of millions of patients. So thank you. Thanks to all
Thank you.
colleagues who are involved in the management of sickle cell patient. And as I always conclude, wherever you are, guys, please stay safe and keep well. And thank you for being loyal to the ICH activities. See you soon.
Thank you.